Okay, so thank you very much for the invitation. I also bring greetings from the South African Thoracic Society. Also like to remind you, and I think Professor Kederer will know, that the Pan-African Thoracic Society is having its Congress in Durban in 2018. So I hope that the SPOI can participate in that Congress. And one of the things we're going to ensure that will happen is there will be a francophone track in that meeting. It's going to be in Durban, where I come from. So following on Sab's, who's my good friend, his presentation, I'm doing the Asthma COPD-overlap syndrome, and I thought it's called ACOS, but I thought I'll call it ALOS, which is the Abdul Gaffar overlap sequence, Lalloo overlap sequence. Okay, so let's change slide. Right, so what I'm going to do is I'm going to start off with a clinical quiz. And if you don't understand my English, I got Buva there who's agreed to translate for me. So here are two patients that I saw in the last 3 months, and they are real patients. I just wrote over some of the spirometric tracing because they didn't copy clearly. Okay, so what I want to ask you as a clinical challenge, right? So these are two patients. One is a smoker with about a 50-pack-year history of smoking. Another one, the other patient has a history of asthma since childhood. Now what I want to ask you is, which patient do you think is the asthmatic and which patient do you think is the smoker with COPD by our conventional...
Smoker is one. Yes.
Smoker is one, yes, very good. Who doesn't agree with that? Who doesn't think that number one is not the smoker? Okay, number two is the asthmatic, agreed?
Yeah.
Both have significant airflow limitation. You could also conceivably say that the second one is tending towards having the typical curve of COPD, right?
Yeah.
But from what Sab said, you can even get patients with COPD who are very mild and may now, with the new thinking, may even have normal lung function. So all is not clear, you agree? And that's a challenge we face in clinical practice, okay? So let me show you the next slide, okay? So these are these patients' reversibility. In one patient, in the first patient, that was historic because I had records from 2 years ago. And the second patient, it was done in October 2016. So now can you tell me, with the reversibility data, which patient is the asthmatic and which patient is the COPD? Do you still stay with your choice that number one is still the COPD patient and number two is the asthmatic? Are we in agreement? Because both, by the figures, have, by the ATS criteria, more than 12% and 200 ml reversibility in the FEV1, right? So let me give you the history. So the first panel represents a 48-year-old female who's never smoked, childhood onset asthma, who's got significant allergic rhinitis and is on a nasal steroid. And she comes in with frequent asthma exacerbations, generally symptomatic, and superimposed on the background of shortness of breath, she gets acute exacerbations. Right, she's got significant reversibility, and when I saw her 2 years ago, I had no hesitation in diagnosing asthma in her. In fact, she has a physician-based diagnosis of asthma from childhood. Okay. Now the next patient, he was seen by his GP a few years ago, and he had stopped smoking about 3 years ago. He smoked 2 packets a day. He's a rich businessman, and they told him he's got asthma, and they put him on Symbicort, which is budesonide plus formoterol. And he was using it intermittently, and he wasn't sure what was going on. Got mild allergic rhinitis, but nothing else. Never had any childhood history of respiratory symptoms, and he can't recall having episodes of bronchitis, etc. He's got a 50-pack-year history of smoking. Right, so he's by our definition, is the COPD patient. Now, when I first started as a specialist, we had a workshop somewhere in South Africa, and we had a discussion about reversibility, and I said that as far as I'm concerned, if you got significant reversibility, you have asthma, and if you don't, then you got COPD. Clearly, we are well aware now that COPD can have significant reversibility as is demonstrated in that patient. He does not have sputum eosinophilia because I took the trouble to measure that. He doesn't have elevated eosinophilic cationic protein, and he's just got mild allergic rhinitis. So in that Dutch hypothesis, or he might be that eosinophilic phenotype, but we didn't identify any eosinophils. So do you understand now the dilemmas we face when we see these patients? And if we don't do lung function reversibility, we won't know what's going on. And when we do it, we still don't know what's going on. Because I challenge you to tell me, what would you label the second patient? I mean, he happens to be a smoker, so why can't he have asthma? And the first patient doesn't smoke, but we know that other things cause COPD, including childhood onset respiratory diseases. So and that patient got more severe airflow limitation than the smoker. She's never smoked, and nor has she been exposed to secondhand smoking. Okay? So when we look at obstructive airways disease, I mean, we can classify airway obstruction anatomically according to where the obstruction is, and I think it's clear when it's upper airway obstruction with tumors, etc. Where the blurring starts to occur, as Subs pointed out, is when you start trying to make clear definitions for asthma and COPD. Then we also see patients with bronchiolitis who may actually be mistakenly diagnosed as asthma with fixed airway obstruction or COPD. Many of them have never smoked. We may get a history of viral infection, and in fact in the last year I've seen 3 such patients who've been labeled as asthma, put on high doses of corticosteroids according to GINA guidelines, even oral corticosteroids with side effects. And in those 3 patients, we made a confident diagnosis of obliterative bronchiolitis, withdrew all their corticosteroids, and it made no significant impact on them except to improve their corticosteroid side effects. So it's very difficult, okay? And then we have patients with sarcoidosis, then we have patients who are smokers who have COPD, chronic pulmonary fibrosis, and emphysema overlap. So life gets more and more complicated, and I think where we created a problem is when we started this huge medical industry of developing guidelines. It keeps many of us in business, it keeps the pharmaceutical industry in business, and it makes also our lives more difficult, because now when we have patients whom we say has got COPD or got asthma and we prescribe a medication, then the health insurer says, no, but these criteria don't look like COPD, therefore we will not approve a LAMA, for example, in this patient. So what we've done is we've created guidelines that have actually compromised or stifled our clinical thinking, and we cannot therefore think out of these boxes. And I think that's what Subs was trying to say when he said we should begin to rethink how we look at these conditions. Clearly there is a place for them. And I think one of the other problems we experience is how guidelines are developed. I call it, there's a term that's used oftentimes, it's called GOB-SAT. So it's good old buddies sitting around the table discussing the guidelines, then it is approaching lunch or dinner and they have to leave, catch their next flight or whatever, and say, hey, you know what, let's quickly accept this. What do the other people know? We'll just write it down and let them sit with it. That's what happens. I'm also getting, as I get older, and you know I'm getting older because I'm getting less hair, I'm getting more and more cynical. In fact, we won't have all these problems if we just ban tobacco production altogether and we provide electricity to everyone so they don't get biomass exposure, and therefore we won't have all these weird obstructive airways disorders. But life's not that simple, okay? So you can see that when we deal with patients with obstructive airways disease, they are a heterogeneous population of people that we are trying to fit in a particular box. And in the context of my presentation, it is about ACOS, Asthma COPD-overlap syndrome, which is now the new boy on the block, which is now put in there to, I think, arrange more meetings and make us more confused. But hopefully I'm being cynical, and that in fact it's helping us to now question how we are defining our patients, okay? So let's examine some of the evidence in these 2 patients. These are, monkeys also do colonoscopies, by the way. Okay, so this is asthma and COPD pathology, and you can see, as Peter Barnes outlined in this cartoon, both have common elements of inflammation, although the inflammatory mediators and cells may be different, okay? So when you look at clinical phenotypes of asthma, like my patient that I presented, she's got a fixed airway obstruction component, okay? I'm not going to go through the other phenotypes, and I think Fan Chung has described the severe asthma research program, which tries to define this patient with severe asthma who have reversibility, eosinophilia, etc., but have a significant element of fixed airway obstruction, okay? And that's the COPD, the asthma component of this ACOS, and then you've got the COPD phenotype that you've heard a lot about. And now Gina, and I'm not going to go through this in detail, has proposed some working definitions for ACOS, okay? So it is overlap syndrome that is characterized by persistent airflow limitation, and you will agree both my patients have that, with several features associated with asthma and several features associated with COPD. In fact, they go on to give you criteria for the 3 different conditions, right? And then what they also say, sorry, the slide came twice, but they've also got a kind of a scoring system. So they said that when you look at your patient, you look at these blocks, and if you got 3 or more, I'll come back to that, 3 or more features in each block, then this patient is likely to have a asthma COPD overlap syndrome. Okay? So that's what Gina is proposing as a working approach or diagnosis to the problem of ACOS. So when you look at both my patients, patient A, onset before 20 years, symptoms vary, record of a variable airflow limitation, previous doctor diagnosis of asthma, she's got a family history of asthma. So she's got 4 criteria that fit in with the diagnosis of asthma. But she also got persistent symptoms, she's got persistent airflow limitation, and her symptoms are gradually worsening over time. So she's got 4 features of each. So clearly by Gina, she's ACOS, right? Anybody disputes that? That's Gina, not me. Okay, now let's go to patient B, the smoker. His symptoms are triggered by exercise. He's got variable airflow limitation. His doctor diagnosed asthma 2 years ago in him, and he does improve symptomatically, either spontaneously or with inhaled corticosteroids. For COPD, age of onset is over 40. He's got persistent airflow limitation. He's got a 50 pack year smoking history, and his symptoms are gradually getting worse over time. So he's also got ACOS. Okay? So do we really need a specialist? And I think what's happening is we have complicated life, but I hope that over time we're going to try and resolve this dilemma, and maybe putting the label of ACOS has actually brought us to our consciousness to say maybe we can't put patients into boxes and then try to determine treatment on that basis. So I think I'll hand over to Subs to have the final word, and then hopefully we can have a robust discussion on how we should move forward with this clinical controversy or confusion that we have created. Again, I'd like to iterate that if we all can stand together and ban tobacco production, 3/4 of our problems in pulmonary medicine will go away, but we might be out of business. Thank you.
Thanks. Thanks, Ramesh. I'll just go over quickly what he said, and this is the definition of ACOS as he stated, where patient has persistent airflow limitation. In other words, you've got to do lung function, several features associated with asthma and several features associated with COPD. But we cannot have, this is more a description rather than a definition, okay? And we can't have a definition until we have more evidence in terms of its clinical phenotypes and mechanisms. And the reason this has all happened is just, we don't have much in the way of data on these patients, because we know from most of the clinical trials, all our patients we see in our clinics are excluded from those trials. In other words, asthmatics who smoke are not put into clinical trials. COPD patients who didn't smoke are not put into clinical trials. If the COPD patient has a history of asthma, he's excluded from the trial. And we know about this growing interest again, or awareness of the Dutch hypothesis. So the ACOS group, by definition, is a large and difficult to control group of patients. But I'll put it to you that ACOS is more a buzzword. It's got no definition. It's not a disease. It may maybe not even be a syndrome. And it's almost like it's a diagnostic workup or a dumping ground. And there's very little or no data in terms of diagnostic criteria, treatment algorithm, and outcomes in response to therapy. And for us back home, we don't have an ICD-10 code to claim from the insurers. And it has generated a number of review articles. I'd suggest you read this one by Eric Bateman in The Lancet, published recently. It's very good. And this is what Umesh has gone over, the steps as per Gina and Gold, where, step 1, you look at all the age, the risk factors, history of asthma diagnosis, history of COPD diagnosis, look at the profiles. Does the patient have more features of asthma or more features of COPD, or does he have features of both? And then treatment, initially, if it's purely asthma, you would follow the asthma algorithm. If it's purely COPD, you'd follow COPD algorithm. If you have ACOS, then you would look at ICS and LABA, and then addition of LABA and LAMA. And Fan Chung showed earlier on the GINA guideline, and this is the GOLD guideline, that for COPD obviously, and that for asthma. And just to stress again the importance of inhaled corticosteroids on this side and bronchodilators on the other side, and the addition of drugs as the disease worsens. And just to reiterate that ICS is important for the asthma phenotype, whereas for the COPD, bronchodilators. And when you're in doubt, rather refer for specialist evaluation. This slide taken from Eric Bateman's article actually summarizes nicely the various factors in chronic airways disease, including genes, ontogeny, disease expression, and environmental factors. And the fact that the airways disease can present differently based on all of these features. And as you grow older, more likely to diagnose COPD and ACOS, and in the younger patient, you're more likely to diagnose asthma. But like I said earlier on, perhaps we need to start looking at phenotypes and think that even asthma has got multiple phenotypes, COPD has multiple phenotypes, and even ACOS has got multiple phenotypes. So is it not time for us to go for treatable traits, meaning look at chronic airways disease, or rather generate more research to substantiate this approach here, which is we look at our patients as having chronic airways disease with certain treatable traits that we define either as phenotype, endotype, and we tailor our treatment according to that, instead of getting into arguments about does he have ACOS, does he have asthma, does he or she have COPD, does he have a high enough eosinophil count, what is the cutoff, etc. Call it chronic airways disease with different attributes, and we look forward to more research that's going to help us define this. Thank you.
Right, so thank you very much. I guess we have time for some discussion. I think the big thing is about this. We've all been brought up about COPD and asthma, and you suggested that maybe we should scrap COPD and asthma, and you think it's too early to do that. But why don't we do that? I mean, things only move when we take big revolutionary steps. I mean, one of the major issues is about the drugs we use, because again, it's all entrenched in it's either an asthma study or a COPD study, and that has regulatory issues also. So we can't really do a big revolution.
I would agree. We are busy reviewing our guidelines, the COPD guidelines at the moment, and I'm having second thoughts about what to call it, and rather say stop calling it one or the other. This is historical, and we must get over it. And the other problem that creates confusion is using spirometry to differentiate one disease from the other.
Yeah.
That's not what spirometry should be used for.
Yeah.
The reversibility has created a lot of confusion. And when we see reversibility, we say this is asthma or ACOS. If you don't, then we say it's this. It just creates a lot of confusion.
Yeah, I think it really goes down to definition of disease. I mean, we define those diseases according to symptoms, basically. Perhaps response to treatment sometimes. So, what I can say from the UBioPret data, I mean, our analysis of the smokers, looking at the omics analysis, would in fact favor the Dutch hypothesis that there are the same mechanisms that are underlying many of those, what you mentioned about treatable traits. And therefore, yeah, I mean, that would support, abolishing asthma and COPD as being the diseases and just focus on, we'll just call it chronic airways disease.
Yeah, I think with time we found
with a particular trait, traits.
we can get somebody in asthma and COPD to replace Fidel Castro and tell us what to do.
Who is Fidel Castro? Ah oui. Je ne sais pas si... est-ce que tu voulais traduire tes questions?
Je voulais juste leur dire que notre ami Gaffar a mis au point un élément important en disant qu'en fait cette notion de réversibilité dans la cause apporte plus de solutions que de confusion. Et ça c'était quelque chose qui est relativement important parce que nous on se basait essentiellement sur ça pour faire la différence chez des malades qui avaient justement un double visage de la pathologie, mais on ne savait pas où les classer. Moi, je suis tout à fait d'accord avec Batman qui dit que c'est en fait une nouvelle créature qui a été créée pour définir un syndrome qui n'en est pas un en fait, et actuellement l'ACOS est totalement revue dans sa conception. C'est ça?
Oui, oui. Donc, on a proposé que toute cette division d'asthme, COPD et ACOS, c'est très artificiel. En fait, on a l'évidence que c'est tout. On peut les grouper ensemble. Ce sont les syndromes obstructifs, avec certains malades qui ont certains traits, d'autres malades qui ont d'autres traits.
Du point, from the patient's point of view, what is important is to have a treatment. So, I think it's a very good approach to take it from the treatable traits. For the point of view of the patient, what he wants to do is, it's a very important point. It's asthma, call it ACOS, call it emphysema. It's not very important. What he wants to do is to be released from his airway obstruction, limitation. And from the point of view of epidemiological studies, I was in the more than 20 years ago, Professor Holland in London. They didn't talk about chronic bronchitis. They talk about chronic airway limitation. The epidemiological studies were done only on chronic airway limitation and how you could treat the patient and give him a suitable treatment for it. So I think it's a good approach. Now, from the point of view of the doctors, we would like to have your expert view. What do you think about it? Because you left us, well, yes, each one of you, Professor Lalloo, Abdul Gaffar. Do you agree with that, of the Dutch definition? Because when I was in Professor Sadul's in Nancy 40 years ago, they all talk about the CPAC symposium. CPAC symposium was in the 1950s, took a definition of asthma which was at that time not on inflammatory, because now we talk about asthma, so, an inflammatory disease. At that time, it is. But the sympathetic model was chronic bronchitis, not even cough, chronic bronchitis. We distinguished it with asthma. Now, as everything has evolved, we are in the molecular medicine.
Yeah.
We must look at out of the biological definitions.
Yeah. Okay. So I think that's where I think we're heading for. I mean, I think what do you call it in French? La nosologie or définition? Donc faire la nosologie sur les symptômes et même sur les fonctions pulmonaires, ça n'aboutit pas à grand chose, non? Il faut avoir une approche. So, defining disease in terms of symptoms and signs and certain tests is not valuable. We need to go into it.
But I think we also need to be careful that we don't create another problem by now subscribing only to the Dutch hypothesis, because that would in itself create further confusion. I think we should steer away from that, because then you've got the British hypothesis, and the British have Brexited, so it's going to be difficult for the two to talk to each other. So I think we should try not to substitute our current problems with new definition, and I think I like that approach of chronic airflow limitation and then categorize patients according to what traits they have, as Sams has proposed, and I think we should start working. I don't think we should radically change anything just yet, but we need to accumulate more information so that we can then recommend an approach with more confidence and not just jump into it.
The problem is that currently we are treating people with chronic diseases, with using treatment which are done with secondary effects, and at the same time we are not defining the problem is here. So we have to do something clear, because from the specialist point of view, we are in a difficult position. Put yourself in a GP, how we will deal. So this is something very important for us to have clear definition to prevent treating people. Not treating people correctly. This is why I'm sorry for the. There's also a problem that we never talk about what the causes of all this. I mean, what Umesh said, we have to put something very important in dealing with tobacco, quitting tobacco. Yeah. This is something very important. And we sometimes we go to treatment and we forget about this important thing.
Yeah. So, in fact, in your first case number 1, I mean, I presume she had a little bad asthma when she was young. Absolutely. And she probably never reached her expected lung function. Okay? And you might diagnose COPD now. Right? In a non-smoking COPD. In fact, I presented this morning data from pollution. When we're exposed to pollution, children exposed to pollution never achieve their. Yeah. So I think this is a category of patients that have been defined by Lalloo. But just to come to your point, it may well be that among specialists, perhaps we should change our thinking, but that that the COPD and asthma still remains the same in non-pulmonary specialists, but that with pulmonary specialists that we need to be thinking much more like treatable traits. But again, that has issues in terms of regulatory issues, in terms of drugs. How are drugs? You have to change all the writings on the drugs. What do you put on the. So that's big effort.
Juste, je vais te donner la parole tout de suite. Je vais dire 2 petits mots et je vais te donner la parole. Je vais parler en français. I speak in French if you want, I translate after. Moi, je pense que l'erreur fondamentale vient de la conception même des deux pathologies. En fait, moi, je pense que l'asthme, c'est une maladie réelle. La BPCO, c'est un concept pathologique qu'on a créé. Et on essaye de lier une maladie avec un concept pathologique, ça ne marche pas. Dans le premier cas que nous avons vu de notre ami Lalloo, c'était un asthmatique qui avait comme facteur de risque le tabac. C'est ça?
Jamais fumé.
Non.
Il avait asthmatique.
C'est un asthmatique. Le deuxième, c'était le deuxième qui avait le facteur de risque. Donc, on essaye de mettre un facteur de risque comme pathologie, ça ne peut pas marcher. Et c'est pour ça que l'ACOS, au départ, il a été biaisé par le fait qu'on essayait de poser ça que sur la réversibilité, alors que nous savons qu'il y a des BPCO qui sont réversibles. Voilà, c'est un peu ça le problème. C'est partir d'un concept qu'on veut rendre par force maladie. Ça ne marche pas. Et c'est pour ça que le GINA 2017, qui vient d'être publié jeudi dernier, il essaie de trouver des questions aux non-répondeurs, en fait, du traitement. Pourquoi? Parce que dans les D, il doit y avoir des D1, D2, D3, D4, des cases de répondeurs qui n'arrivent pas à déterminer de façon standardisée. Muller.
I'm just talking as a clinician. I'm not a scientist. And I say that this ACOS syndrome or anything else, I recognize a lot of my patients in this definition. And for me, it's a good thing. Even our big boss say that it's not.
But I think ACOS came about to actually alert us to the problems that we created. And in fact, it is moving towards us now coming to a more common understanding of this airflow limitation syndrome. And what's more important, as we know, is the treatment and prevention of future conserving respiratory health for the future.
Okay, I think we should just close the meeting, but just to recap that we've had a very good discussion about ACOS, asthma and COPD, and I think this field is just going to evolve much more, and I think there will be great progress as we do more of those omics type studies to try and find the various phenotypes. Thanks very much.